So here's a full video of what we do in the office here when we nasal intubate. The patient was a rock star. He was on board with us, video recording him, posting it on YouTube, Instagram, wherever we wanted to. He was all for it. Really, really nice gentleman there. That's my colleague there, kind of getting things ready. We have the patient breathing oxygen to kind of fill their lungs up and give us a lot of reserve in the lungs, which is what we like for this situation here in the office. That's my colleague giving the propofol, getting the patient sleepy. Patient already got other medication to get some pre-sedation on, and the propofol is what essentially puts the patient to sleep. So as you can tell, the patient's breathing, starting to really get relaxed there. That's the McGrath laryngoscope, and that's the nasal tube we're going to use. It's going to go in through the nose and into the back of the throat and beyond the vocal cords into the lungs, essentially. You can tell his eyes are starting to drift off there. He's getting sleepy. He took his last breath there. Those are the vitals. I always like to show those just to kind of show everyone that the patient is super, super stable the entire time throughout this procedure. And there's my colleague giving a few breaths of oxygen just as we kind of set up and let the medicine kick in. We have an awesome anesthesia tech there with us, so he hands her the McGrath. He gets the nasal tube ready, and my colleague here, this is a really, really cool learning experience for anyone that does these or has ever done these. The patient said the left nostril is easier to breathe out of, and that's usually a hint for us to go that way, that it might be an easier passage. But as she tries to gently pass it through, she's struggling a little bit. And I think after, a few attempts to get it past there, she says, let's try the other side, even though she wasn't planning on it. And that's normal. That happens sometimes, and it does cause a little trauma. And as I show you the screen here, you're going to see a little bit of blood, but see how it passed really easy on the other nostril? So as we get our view here, look at the vocal cords here, and as the tube comes into view, you can see the cup has a little bit of blood on it. That's okay. That's normal. We expect that. Not a whole lot we can do. And what she's doing here is gently twisting the tube to kind of let it glide right in, and you'll see it pass through right there. Boom. We're through in the vocal cords. We got some blood. What we'll do is we'll suction back there. The anesthesia tech, he's so good. He's suctioning, and I let him know, let's get a little deeper, go a little deeper to get that blood, and he does. Gets the blood out. We'll put a little throat pack back there to absorb any blood. Patient's very comfortable asleep right now. We don't use any paralytic on these. We try not to, at least. And about 90% of the time we get by without using paralytic. So tube's in place. Cuff is up. We have him connected, and now she's going to give him a few breaths here, just to kind of, as you can see the fog in the tube there, that's CO2, and there you go. Desatted a little bit to 93, but he's perking right back up. Pressure looks good. Heart rate looks fine. We'll put him on the pump and get propofol kind of flowing through, so he kind of stays asleep with maintenance anesthesia, and we're just kind of suctioning him out one more time, make sure we get all that blood, because we don't want anything else to kind of go into the stomach or the lungs. And this is the cool technique that we use here to kind of keep the tube in place and keep the patient's face safe, the eyes safe. I like to always do one piece of tape that at least attaches to the patient's skin, because if all else fails, and let's just say our tape job fails otherwise, we always know we have something attached to the skin, so it should not essentially fall out of the nose or the trachea for that matter, and the patient self-extubate. We do not want that. So showing you the vital signs again, patient is yet to start breathing, and we expect that. There's about a 5-minute window here where the patient is not breathing on their own. We give them some support breaths, but for the most part, we like to let the CO2 build as well so they can start to breathe. And there she's giving a little propofol because the patient was starting to react a little bit. So we want to make sure we keep that fine state of anesthesia for them. So this is the awesome tape job or towel job that we use to make sure the patient's tube stays in place and it protects all the facial structures and stuff. So one tape right across, and then we'll do a few more, and we will secure this baby down, and patients do really well. This patient did awesome, woke up just fine. That's our little setup there, and I'm actually giving the patient a few breaths here, and you'll see the fog in the tube there. And eventually the patient starts breathing on their own, and they breathe on their own the entire case. These patients do amazing. Thanks for watching. That's our video, and that's my awesome call.